because Iago just the countdown there, and I will first tell some informations about the meeting here, and then I will introduce it to one of you, to everyone that is watching us right now. So, welcome to the first webinar of the DENEM about the health systems and medical education across the globe. And this first week will be with Americas, yay, best versions. And for the students, we'll agree that if our students watch at least at least 3 of the 5 webinars, they will get certificate. So for that to the students show that they're here, that they are in this meeting, we have a link in the description of the YouTube that they can put their names for the certificate, and also there is another link for questions. So don't ask on the comments, just ask in the comments in the forums, and you can send as many questions as you want. Like you can fill the forms many times as you want and send it, and you don't need to put your name if you don't want to show who you are. And okay, you can ask questions for everyone or just one of us at any time of the meeting. And okay, so I'll present our guests today. We have Rafaela and Yihung from Quebec, and we have Veronica Alredo from Mexico, and Gabriel from Honduras. Perfect. So I will first start with the presentation of Brazil, so about our health systems, and then I will give the word for the girls from Quebec, so they can be the first guests to talk. And I will be very quickly because, well, if most of our listeners are Brazilians, then they already know it. But I hope we have people from all over the world, and then they'll get to know more about Brazilian health system as well. So I will share my screen in a bit. I just okay. I hope it works now. So the Brazilian so how is our system organized? Our system is called seus. That's how it's called in Portuguese. And in Portuguese, it means Sistema Único de Saúde. And the translations for English would be Universal Healthcare System. It's public and free, and its principles are universally, equally, and integrity, which means that everyone that lives in Brazil have access to the system, and it's free. And even if foreign people come to Brazil and they need medical attention, they will get for free. So they won't, like if they suffer some kind of accident, they will be they will be able to have medical assistance for free, and they won't leave the hospital with like big bills. So they will have for free everything, and if they live, foreign people live here, they also get everything for free. The only difference is that foreign would only get like tertiary care, that is more emergency, and not the primary care, which is only if you live in Brazil. So everyone have the rights to have access to the system, and they distribute the effort according to the local necessities. So if one community needs more attention than other, they will have more units of basic healthcare, or maybe more hospitals, and maybe more people working there, and more teams that I will explain why I said more teams later, and that's it. And also, we try to see the patient as a whole and not because of one disease they have. So if a guy come here with headaches, of course we will try to see why he have headache or anything, but we will also like see everything from the head to the toe, try to like see if they have something more, if they have others alterations in the exams or everything, so we can treat as a whole and not because of one symptoms they have. So our healthcare system is organized in 3 instances: national, state, and municipal authorities, and they're all responsible for making financial assistance. So each one of them, like they put some of their money for the government money there to make it work and make it better. So as much as the municipal pays more money, they like will be the system will be better. But okay. So the healthcare hierarchy is also divided in 3 levels. So we have the first level of healthcare, which will be the family medicine. The secondary will be ambulatorial, so like for specialties like endocrinology, ophthalmology, and cardiologists, there will be secondary healthcare. And the tertiary healthcare level would be hospitals. So if emergency or any way that we need to go to a hospital, that will be tertiary care. And we also have, some people also say that we have 4 level. That would be like if you have some sequels, like if because of one disease you have something like getting wrong, then that's not normal, then you have like physiotherapy to make it works, and that would be the 4th level. Okay, so the primary care, here in Brazil we call it the basics health units, or UBS, and we have like one in the city. We have one units, basic health units for the territory. So like the city is everything in this map, is everything that is colorful, not the light pink here, but everything that is color is the city. And for this red, for example, we have one basic health unit for this territory, and this one basics health would take care of everyone there. So they, as it's a big region, they probably have a lot of teams working for get all the families that live in the community. So everyone will have attention, at least if they don't need, because in Brazil, most people have insurance, and those that they don't usually go to the public one, but the ones that don't have it, they need the Brazilian healthcare systems. And also the ones that have insurance, sometimes they need SUS, because sometimes treatments, they're only given by our healthcare systems. So yeah, I think that's it from here. And how does people take part of our healthcare system? We have a popular participation, which is everyone can participate in the meetings. So the local meeting from my community, they have this meeting, and the healthcare councils and conference that we can participate and make part of the decisions they're doing for our community. So if I go there, I can like help decide anything from that they're trying to do for our community, like maybe putting more doctors and trying to have physiotherapists for the community and everything that the community needs. Not all of people goes to this conference, but it's really important that everyone could go, so they make like a difference for the community. And yeah, I think that's it. So about our medical education now, so we're almost in the end. Our medicine is a 6-year course, and we divide it in 3 blocks. So the first 2 years of medical is the basic cycles, and it's more like biochemistry, anatomy, so the real basics of medicines, and we not everyone have already in those first 2 years contact with patients, but then we have clinical cycle in the third and fourth years. That is where we have like our first contacts with patients, and we practice all the clinicals that we have, like cardiologists, pediatrics, endocrinologists. So everything we have from the clinic, we have in those 2 years. That is the third and fourth year. And for last, we have in the last 2 years, we have internship cycle, and we we are obligated to do it in the last 2 years. It's not remunerated, so we are like slaves in the hospitals. But we basically try to pretend to be the doctor, like to make it like so we know when we are the real doctors, we know how to do it. So it's really an internship to practice everything as much as we can, so we can like be prepared to our future. And we basically in this internship we spend a few time in the gynecologist and obstetrics department, and then in surgery and internal medicines, like all the specialties in internal medicines, public health, and pediatrics. So we try to be in those 5 areas as much as we can in those only 2 years. But this is where we learned more and we have more practice. It's basically all practice, and we have very few like classes in those 2 years. And that's it. At least that's for the part from Brazil. I will stop here. And well, if you have some questions, we can ask in the end. And Juliana, do you want to say something else more?
No, I think you did good.
Perfect. So I think Quebec can go next. So Rafaela and Yihong.
Yeah. All right, I'm just gonna try to show my sharing screen skills. Here we go, hopefully.
Perfect.
It's working, right?
Yes.
Okay, super. So Yihong, you're all right if I start?
Yeah, it's perfect.
Good. Okay, so hi everyone, thanks for being here, and thanks for inviting us. It's a real honor to be here with you guys and to present Quebec's health system and medical education in Quebec, as well as a part of the Canadian one, because as you might know, Quebec is not a country. Even so, some people would like it to be. It's still part of Canada, so we're going to try to tackle both the Quebec's and Canada's health system and medical education. So yeah, let's start. All right, so the healthcare system in Quebec has four pillars, four basic principles, which are universality, equity, public administration, and accessibility. So basically, it's to aim towards the universal health coverage, which implements that everyone gets the same access, the same access to medical treatment, regardless of their socioeconomic levels or their salary or anything, even like physical barriers of territory and stuff. So everyone should be able to have access to a proper medical system. And it's covering all 18 regions. So from the parts where we have Montreal and Quebec, which are more bigger cities, towards all the rest of Quebec, containing regions and like Aboriginal populations and such. And it is also mixed, which means it is publicly funded, but also to be sure that every Quebecois, has access to every services that they need. The system is also combined with private services such as dentists, pharmacies, drugstore, and stuff like that. The system contains various public services such as hospital centers, such as local community services, and something similar as nursing homes for elder people that want to retire in somewhere more peaceful and more, how would I put it, more mental focused and medically focused to tackle their needs better than in any other house. Readaptation centers as well are publicly funded, and childhood and youth protection centers as well. So that would be for the public part, sorry. And for the private resources to fill the healthcare system in Quebec, we have general practitioners group and clinics, which we call GMFs, Groupe de Médecine de Famille, which are clinics of many medical practitioners, as the name says it. We also have dentists, as I said, which aren't covered by the public services we have. We also have private clinics and everything. Pharmacies and drugstores are privately owned as well. We have community organisms that are private too, and private residencies for elders with health services exist as well for people that would want to have a more diverse options for their parents, grandparents, or for themselves as when they retire. So, all right. So yeah, that's exactly what I said. I didn't switch the slides, sorry for that, but the healthcare system is complementary, has complementary private services as dentists, pharmacies, drugstore, and such. So here we go. All right. So most fees that are coming with any medical services or medical operations or everything are covered by what we call the health insurance regime of Quebec, or RAMQ. And so we all get this card, which is called the sun card, which is pretty funny because, as you can see on the picture, it has a sun and people tend to call it the sun card. So now you know that. Not sure if it's going to be helpful, but now you know it. Yeah, so it's that's the public part, which reimburses, for example, the medical consultation you would get for the general practitioners you would consult for any type of illness, any type of headache, any type of muscle pain, whatever. That would be covered by the health insurance card or the RAMQ. So yeah. And though there are some services that aren't covered, for example, now it's new. We have, since 1997, we have an additional medication coverage, yeah, that is added up to the public services of healthcare that are covered. So now people don't always have to pay for their medication, which is amazing. For example, contraception is covered, at least partially, by that new regime of coverage. So it gives the Quebec's population a better chance to have access to the proper medication without having trouble paying for it. Though there are some medications that aren't covered by it, and most people would buy a private additional medication coverage insurance to pay for the medication that aren't covered, so that they don't have to pay extra incredibly high fees for it. And to be admissible to have the health insurance card, of course, if you live in Quebec and are a Canadian and Quebec resident, you have it. But as well, if you are a student from anywhere in the world and are coming here in Quebec to have a certain type of studies with a scholarship, you are admissible to the healthcare, as well as someone coming here for work for a government program or anything. And something that is pretty interesting as well is that Quebec, the health insurance in Quebec is also applicable to the rest of the Canada. So if you go to another province, for example, Ontario or British Columbia, you can still pay some of the fees of your medical consultation or medical services you could require with your RAMQ. So this is pretty interesting. And the most interesting part is, and most Quebecois don't even know, but if they travel, they even can pay some of the things with the card and with their health insurance from Quebec. But that's a very limited amount of acts, of medical acts that are covered. So usually people pay for an extra travel insurance, especially in those weird times as we are now. So that is for it. And the funding, it is funded mainly by taxes, so people will pay a different amount of taxes depending on their salaries, and most of that will go to the health system in Quebec, which among others pays for the health insurance system to provide every Quebecois and every Canadian with the proper health services. And the limits, we are currently tackling some problems. Among them, there is a lack of accessibility to the proper medical services for every Quebecois regarding the region in which they live in. So, for example, someone living in the main cities like Montreal, Quebec City, and like the bigger cities have no trouble for that. But if you live farther away in the suburbs or farther regions, sometimes it's hard for the services to be able to reach you because there are no routes. So you can't go by car, you have to take the plane, or because no one wants to work there because it's far away for their families and the cost of life is more expensive, so people don't tend to work there. So that is something the government is tackling right now to encourage new practitioners and new medical students that are becoming doctors to go work there to be able to provide with the population with the proper services for which they pay with their taxes. And as well, we have a very intensive waiting line for our services, especially in the public area. So people could wait a few years to have a knee surgery, or they could even wait like even a year to have just a global visit with their family doctor to check if everything is all right. So that is a big issue we're working on. And some people don't even try to reach out to the health system because they know they're going to wait a lot of time. And that is a problem because as a population, we want to encourage people for prevention of preventable diseases. And this is a very big part of the first line, which people don't get access to as easily because of the waiting. So that is one of the reasons why in 2005, the government decided to encourage more private services, because encouraging more private services, as I said, the healthcare system is mixed with public and private. And the private part, by growing a bit bigger, would unclog the public one, which would permit for some people that can afford the private one to go there and to go faster and to, skip the line, while people that would be totally okay public and wouldn't be able to afford going to private, or just wouldn't have the chance because in their region they don't have anything private, then they would be able to go to the public one without having an enormous waiting line and waiting time for nothing. So that is basically the strategy we're trying to tackle down for now, and let's hope it works in the years to come. But for now, it's still a big issue. So I guess that is it for Quebec. If you have any questions, feel free to ask me at the end of the presentation. I will be more than welcome to explain some more to you. And then for Quebec part, the universal coverage for medical treatment is called Medicare. And basically, it's the same global idea as Quebec's, which is to give the opportunity to every citizen of Canada to have access to proper, equitable, and just adapted medical services and medical acts. So yeah, and the different, sorry, I'm just a bit lost in my things here. Yeah, so in 1984, the Canada Health Act decided to offer financial support to provinces and territories, and well, for the medical and healthcare system, and they, like in Quebec, decided to fund completely or the most necessary services for the population totally. So people wouldn't have to pay to go visit a doctor, or because they would have a I don't know, they would need a very life-threatening surgery or whatever. They wouldn't have to pay for that. So based on the public view of administration, based on comprehensiveness, based on universality, based on accessibility, and based on portability, the Medicare and the Canada Health Act were created. And something important about the fifth principle of the Canada Health Act is portability, and it says that it must cover all insured persons when they move to another province or territory within Canada and when they travel abroad. So this means that every Canadian traveling within Canada is covered by it, but also if they would travel abroad Canada, that they will also be able to get some services from the Canada Health Act and the Medicare. So that is pretty interesting for people that would like to travel or that like traveling. And then there is another service that is pretty interesting, because as I mentioned previously, the dental treatment and services aren't covered by, for example, the Quebec's health insurance. But in Canada, they decided to tackle some groups of population for which they deliver free every services they would need. For example, First Nation people living in reserves, Inuits, serving members of the Canadian Armed Force, veterans, inmates in federal penitentiaries, and some groups of refugees claimants receive everything free. So they don't have to pay for glasses, they don't have to pay for a dentist, they don't have to pay for medication at all. Everything is covered for them. So that is the groups of population in which Canada decided to prioritize the healthcare and to really want to tackle that a bit more. So I know it was really quick for Canada because, you know, Canada should be talking a bit more about Canada, but it is pretty much the same as in Quebec. The same valors are there, the same pillars are there, the same principles are there. Basically, it's aiming towards universal health coverage, and that every Canadian and every Quebecer gets the treatment they need, regardless of their salaries and regardless of the place they live in. So that would be all for me. I'm sorry, Hong, I hope I didn't take too much time. So you're next.
That was perfect. Thank you, Rafaela. So hi guys, I'm Yi-Hong from IFMSA Quebec, and I'm going to talk about the medical education in Quebec. So in Quebec, there are 4 medical schools. And for the medical schools in Quebec, they do not require a bachelor's degree for entry. So you can apply after a 2-year CEGEP. It's like a college diploma. And so there are 4 medical schools in Quebec. In Montreal, there are 2, University of Montreal and McGill University. And for these 2 schools, it's a program of 1 year of pre-med plus 4 years of med school. In Quebec City, so at Laval University, you can choose between 4, 4.5, or 5 years of med school. And so Rafaela and we go to Laval University, the both of us. I'm doing it in 5 years, and Rafaela is doing it in 4.5 years. And then we have in Sherbrooke, we have University of Sherbrooke, where it's 4 years of med school. Okay, and so we have pre-med. Pre-med, it's 1 year, and it's only in the Montreal schools. And it's basic science, health science courses such as anatomy, physiology, and biochemistry. And so after pre-med, we have med school. Med school is basically 2 years of pre-clerkship plus 2 years of clerkship. And in Quebec City, so in Laval University, we have a choice between 2.5 or 3 years of pre-clerkship, and also we have 2 years of clerkship. And so the pre-clerkship consists of theoretical classes such as pulmonology, cardiology, and neurology. And we also have practical classes to learn how to do a medical interview and a physical exam. And then we have clerkship, where students go to the hospital and have rotations in different departments, such as family medicine, internal medicine, and emergency medicine. And now I'm going to talk about the medical education in the rest of Canada. It's quite different. So there are 17 medical schools in Canada, 4 in Quebec, and 13 in the rest of Canada. And most medical schools require at least 2 or 3 years of university study before application can be made to medical school. And med school is usually 4 years in Canada and the rest of Canada, but there are some exceptions such as McMaster University and the University of Calgary, where it's 3 years of med school without interruption for the summer. So us in Quebec, we have a break for the summer, but in other universities such as McMaster and Calgary, they don't have any summer. They have to go to school during summer. And another thing that we wanted to talk about is it hard to get into med school in Quebec? And yes, it's pretty hard to get into med school in Quebec. The percentage of applicants who receive an offer of admission is pretty low. For example, in McGill University, it's 7%. At University of Sherbrooke, it's 7%. Laval University, 9%. University of Montreal, it's 10%. And so now I'm going to talk about the CARMS. The CARMS is the Canadian Resident Matching Service. So in order to apply to the CARMS, you have to prepare a folder of application with a letter of intent, a CV, and some recommendation letters. And also after the process, you have to do an interview for each school and specialty that you're applying to. And so the students rank their preferences and specialties, and the programs also rank each student. And then with a computerized matching system, you get matched with a program and a school that you chose and that you rank. Okay, so now I'm going to talk about the residency length. So in family medicine, it's 2 years of residency, and internal medicine and pediatrics, it's 4 years. And for other surgical residencies, such as cardiac surgery, neurosurgery, and general surgery, it's 6 years. And also there's a possibility of doing a fellowship after residency, and the fellowship can be made anywhere. Like you can go to Australia or go to Europe. There are a lot of possibilities, and it's optional, and it's for a further training and a specialty. So it's like a subspecialty. Okay, so now I'm going to talk about the class profile for med students. I have an example for McGill Medicine. It's a university in Montreal. So I got the statistics for fall 2019. So 179 med students were admitted, and it consisted of 58% were female and 42% were male. And the average age was 23, and the ages ranges from 17 to 40. And also 12 students have achieved a master's degrees, and 5 have achieved a doctorate degree. So the classes of med students are really diverse. There are also parents who have children who just got admitted to med school, and there are also people of 17 years old. Like, it's super diverse. And finally, here are some facts on Canada's physicians. So presently, there are 86,000 active physicians, excluding residents. And per population, there are 2.41 physicians per 1,000 of people in Canada. And so 52% are family physicians, and 48% are specialists of other disciplines. So it's almost half-half. Also, 39% are aged 55 and older, and 43% are female, and 57 are male. But if you remember, now med students, there are 58% female and 42% male, so we're getting balanced for the percentage of female and male. And yeah, that's it. Okay, and now I see you guys have some questions. So we have a question by Amanda Buchik. How is made the choice between 4.5 or 5 years of med school in Quebec? What are difference? That is a really good question. So I'm doing my med school in 5 years. So when I'm doing it 5 years, it's basically 3 years of pre-clerkship and 2 years of clerkship. And it really depends on you. If you want to do your mid school in 5 years, it's more relaxed than if you want to do your med school in 4 years. It's also possible to do it in 4 years. It's like 2 years of pre-clerkship and 2 years of clerkship. And Rafaela is doing her med school in 4.5 years. So if you want to talk about it.
Well, the reason why I decided to do it in 4.5 is because I wanted to travel. So basically, when you do it in 4.5, you have the end of your summer sessions of your second year, which is just about like a month before now. I just finished it. And until that moment, so the beginning of your summer of your second year, until Christmas of the next year, you have no classes. So basically, from now on, I don't have any medical classes until Christmas, which was a time that I wanted for traveling, which, as you might realize, I am not doing and would probably not be able to because of the situation right now. But most people, some people also decide to take 4.5 year to do a master in research or in any other subject that they are interested to, because the medical studies can be really hard, and you don't really have the time. Most of people don't find the time to do a master at the same time, so they take like a 6 month off to finish their thesis and their research project for that. I guess you skipped the question, Yihong. I think I have, do Canada's health system cover foreigners when they need?
Oh, yeah.
This one is a hard one. I think very few foreigners can be covered by the medical system. Like the emergencies will like take you in, they will give you the services you need, and they will provide you with the services, but you will have eventually to pay for it. I am pretty sure it's not the total cost. So like you wouldn't have to pay thousands and thousands of dollars if you just go for a consultation because you have a stomach ache. But you would have to pay a lot more than a resident of Canada would have to. So maybe if you were planning to travel to Canada and Quebec, it would be a smart idea to get yourself health travel insurance.
Great. So we have another question. Can strangers apply for residency in Quebec? And yes, it is possible. So in order to apply for residency in Quebec, you have to have an equivalent of diploma of the Collège des Médecins. It's basically Collège des Médecins du Québec. It's basically the College of Doctors of Quebec. So in order to have an equivalence, you have to succeed in 2 exams. So you have to go to the Conseil médical du Canada. It's like the Medical Council of Canada. And then after succeeding those 2 exams, you can ask to have an equivalence of the diploma. And yeah, so it's the Collège des Médecins du Québec that will approve if you can have your equivalence or not. So if they approve if you succeeded in the exam and that your inscription is approved, then it's possible to apply for residency in Quebec?
Yeah, that's basically it. Okay, so we know that Canada, am I skipping one? No, okay. We know that Canada have 2 languages. I'd like to know how it works in the health system. Is there an official language on that, or it depends on the city? Thank you. Well, in Quebec, the main language is French, so everything is in French. Of course, every medical practitioner, every doctor has to have a certain level of English because it's our second official language. So we have mandatory English classes if we are not fulfilling the requirements of English we need to for becoming a doctor. So most people usually have them when they quit high school or cégep, which is kind of like a college. But if people did not meet these requirements, they have to take extra English classes during their studies. So basically, normally everyone could be served and treated in English in Quebec, as well as in the rest of Canada, obviously, because the rest of Canada mostly speaks English, which leads to the second part, meaning that the rest of Canada is basically in English. The studies are made in English, contrarily as in Quebec, which we have 3 out of 4 universities that are entirely in French. There's only McGill in Quebec that provides medical education in English. And yeah, there are some French francophone hospitals in the rest of Canada, as in the north of Ontario, which there are a lot of French Canadians, but most universities that aren't, and most hospitals that aren't in Quebec are in English. Hope that answers your question.
So I think we can follow now, and then we go back to everyone's questions, so we do like everything together.
For sure.
Okay, so because we have more questions in the questionnaires in the forms that there's linked on the YouTube link, so there's
Right.
more people asking. Okay.
Yeah.
So now I think, Vero, do you want to be next?
Sure, it's fine. Okay. Can you see my presentation?
Yes. It's perfect.
Perfect. So, hello everyone. My name is Veronica Moreno. I'm from Mexico, and I will explain a bit of the Mexican healthcare system and Mexican health and medical education. So, first, a general overview of the healthcare system in Mexico. You have to know a lot of things. First of all, it's extremely complex. It varies from state to state. It's provided by public institutions run by the government departments, private hospitals and clinics, and private physicians as well. The affiliation to any of the existing programs not determined by the financial situation of the individuals, but for the employments that they have. And 18% of the population has not any type of healthcare coverage yet in Mexico. So, who takes part of the national healthcare system? Public and private institutions that provide healthcare, and it's divided in the federal Ministry of Health, which is also divided into 32 ministries of health, which means that each state has their own Ministry of Health, and 13 national institutions. It's just like general such as epidemiology, cardiology, and so on. So here's something to help you understand a little bit more about our healthcare system. So we have first the sector, and then the buyers, the providers, and the users. So as you can see, it's in Spanish because this is the only way that I found it, but I will explain it. So it's divided into public and private systems, or areas, and we will start with the private area because it's easier. So the private area, it's a sector, and then the be from the individuals or for so we will start with employers. Employers pay to private insurances. The private insurances pay to the private providers. The private providers just give the insurance or the insurance service according to the amount of the employers. Then we have the individuals, that the individuals can either go to this system that I will later, could go to Seguro Popular, which I will later explain. It's not available anymore, at least in some states of Mexico. They can also go to the Ministry of Health, and they could also go to the private insurance, pay to private providers, and then go and receive the healthcare that they needed. And then we go to the public sector. This sector is more complicated and has a lot of variables. First, we will talk about social security, which can be by the contribution of the government, by a contribution of an employer, or by the contribution of the people with employees. Or the employees, I'm sorry. So we have several institutions that I will later explain, but basically the social security is you get funds from either of these three, of the government, the employer, or the employee, and they get their healthcare coverage for not only for them. Some of them get for the families of the healthcare of the employees, and others for the people that is not long health mainly. So when the taxes or the contribution to the government and the contribution to the state, to the governments of each state. So we have federal and state statutory or state. So the state government can have the same opportunities that we have in the social security, but they can also have another kind of securities just implemented by the federal governments, and the contribution of the federal government has the health ministry, as I already explained, and it's composed by hospitals, clinics, and other institutions or medical workforce that works there. And well, this goes for people that is has, like, for example, stores that they are paying themselves as they're employing themselves, or people that does work, or people that does not works in a formal area. So we have people that works in the public area and people works in like informal areas. Then, as I was telling you, we have Seguro Popular, which I will explain a little bit simpler each one of them. Seguro Popular was created in 2000 by Julio Frank, who intended to create, or it was an intent of the health ministry to achieve universal health coverage. It covered any Mexican citizen that was any Mexican citizen, regardless of their work status, and it protected around 57 million of Mexicans, covering almost 260 of the most prevalent diseases. And 18 high-cost surgical interventions. And as I'm telling, as you can see now, I'm talking in the past, because the current president removed this social service, or Seguro Popular, and replaced by Instituto de Salud para el Bienestar, which is the health Institute for the Well-Being, or INSABI in a short form, which was a social service not created by healthcare professionals. It was created by the government. So it is not yet available in every part of the country, but some of, for example, in my state, we are still stuck with Seguro Popular, which is so much better than INSABI. But well, we are expecting it to get better through the years, hopefully. But yeah, we are not sure yet on how it's going to go, this new initiative from the government. Then, as I told you, well, the Seguro Popular or INSABI was for people that worked on an informal part of the of like had an informal job, or that didn't or that was deployed. But now we're going to talk to for the people that is that has a formal employment. So we have people or employed citizens in their dependents. So the here it's most likely employer pays a small fee for each of the employees that he or she has, and to the Instituto Mexicano del Seguro Social, which is a short form or shortly known as IMSS. And this is a tripartite system funded equally by the employee. We have a small fund from the employee, a small fund from the private employer, and the federal government also pays a small fund. And this covers almost around 65 million people and all the programs that it has. And then we have the people that works for the government or public employees. So this is the same system as we discussed with IMSS, but this covers nearly 8 million people, which is this part is called Instituto de Seguridad y Servicios Sociales Trabajadores del Estado, or short form ISTE. Then we have other institutions also in the public area, also for workers. We have workers for the army, workers for the marine, workers of petroleum system, the petroleum main system in Mexico, and together they cover around 1 million people. And we have the state governments. Covers or provides an independently healthcare system. It depends, as I'm telling you, to each state, and most of them stay only with the federal. And well, in numbers, what can we summarize from this? The Free Health is the largest public healthcare institution operating through 809 hospitals throughout the country. IMSS grants hospital care and services to employed citizens in their dependents, and had 279 hospitals affiliated to it. The ISTE grants hospital care and services to the government employees and has 155 affiliated hospitals. And other institutions have 279 hospitals affiliated to 9 government dependencies. And well, now I will talk briefly about the medical education system in Mexico. Another general overview. Generally, our university, as I already said, it varies from university to university, as well as the healthcare system varies from state to state. It can last between 6.5 to 7 years, depending on the university. And it is most likely divided into 5 years of medical school at the faculty, 1 year of an internship where the student is meant to different areas such as pediatrics, medical internal medicine, surgery, and family medicine, emergency, and gynecology and obstetrics. And 1 year of social service. This can vary. This is really important to clarify that it varies from state to state and from university to university. For example, my university has a three-year system on the medical faculty, 3 years at the hospital, and 1 year of social service. So basically, I'm like 3 years having all the shifts in different departments instead of only having 1 year of internship. And then we have a competency-based approach, and there's around 158 medical schools. However, only 111 of them are accredited or in process of accreditation. As a global context, what the medical education in Mexico seeks or is intends to seek because not everyone or every school has the same approaches, is this a physiology approach. I'm sorry, which means integral and developing physicians with sustainable competencies, which means that they use all the theoretical, scientific, epidemiological, and clinical knowledge when they come to make a decision. Then we have epistemology, which is the construction of the knowledge. Then we go to sociology, which is the social perspective of medicine. Then we go to methodology, which is all the advances that medicine and science have. And then we have the area of pedagogic, where the knowledge is implemented in some projects that the universities offer. And well, that's basically a summary. As I told you, it's really different from university to university. So I cannot have a general or national context on how each one of the universities in Mexico exist. Now I will talk about the specialty or residency in Mexico. You have to take a test called Mexicano, which means well, just the national residency exams in Mexico. And well, it's 450 questions based on clinical cases. That each question or each rubric or each clinical case is elaborated by at least 8 medical experts, and it has like 4 main general categories: internal medicine, surgery, pediatrics, and obstetrics and gynecology. These are all the specialties that you can have in Mexico. It's from 3 to 5 years depending on the hospital and depending on the residency that you'd want to take. Some places have surgery for 4 years. Some other have surgery for 5 years. Can take only 3 years, others 4 years. It depends on the curricula that each hospital has and decides. Once you have to take the test, it is a test that it's taken in an electrical form or digital form. You go to a place, they give you they provide you with the test, and when you end the test, they give you the results. However, you have to wait until the results are arranged from all the results in the country, from the high to the low. There is like ties. There is different ways to revise those ties and see who is selected or who gets the higher number. And after everything of this and everything is analyzed and all the information is analyzed, the participants are just shared through media, and the hospitals start calling them. So only, for example, let's say we have 10 spots, had 20 applicants. The first 10 higher scores get in for each, depending on each one specialties that they want. For example, if if 5 of those 20 wanted surgery, but surgery had only 2 spots, well, just the first 2 numbers or the first 2 highest scores of that apply to surgery get to do the residency. And well, that's basically it from me. Easy as I can, but it's really, really complicated to explain. just works. So I think now it's Gabriel's turn.
Okay, thank you, Vero, for everything. We will have questions at the end. So after Gabriel present, we can have questions for everyone. We already have some questions in the form. So Gabriel, it's your turn.
Okay, do you hear me right?
Yes.
Okay, perfect. So hi guys. As well as I presented myself on the beginning, I'm Gabriel. I'm from Honduras. I was born and raised here, and as different as like for example Canada and Quebec as a province, or Mexico or Brazil, we're all obviously a really small and tiny country compared to those huge countries, but we have big deficiencies, and that I will try to explain to you today, sadly. So first, the Honduran healthcare system. So our healthcare system is divided into three, but I will just explain two that are the ones for the public sector. The other one is the private sector, that you have to pay pretty much everything by yourself. And as I said, everything. Since just a syringe, you have to pay it everything for everything. So this sometimes is paid by, for example, insurance companies. Obviously, if you have like your insurance ID and everything. But what I want you to understand is the social healthcare system, like the public one. So it consists on two subsectors. The first one is the public, fully public, that is composed by the Ministry of Health, and it corresponds to the Ministry of Health to give to provide health to all the population in Honduras. Sorry. And the next one is the Instituto Hondureño de Seguridad Social, or Honduran Social Security, that is obviously pretty much like the IFMSA of Mexico, and for us is they charge, they collect, and they manage resources and compulsory contribution from workers and employers. Also, there is like the private subsectors, as I told you, that they also have, the private sector has to pay for the social security also, just as Mexico, pretty much the same, and employers. And the health secretary also provides services to 60% of the East, secures 12%, and private sector accounts for 10%. In Honduras, almost 9 out of 10 people are not covered by any kind of health insurance, and it is that 18% on the more than 1 million Hondurans do not have access to health services. Right now, we are 9 million person. So like our population is 9 million people, and we like more than 1.5 million Hondurans do not have access to any type or any type of medical service. So what about the hospitals? Well, our infrastructure and health centers are very deficient. We just have two main, well, not just two, but at least the ones that have more patients, and they are like the state hospitals that are the ones who receive the majority amount of patients, is in the capital city here in Tegucigalpa, and in the northern city, that is where all the industry is San Pedro Sula. So there are just these two hospitals, and I will explain a little bit how does it work this. So all these public centers are from the beginning of the last century and require heavy investments in infrastructure and equipment to provide the services in an optimal condition and free of risk. So all the maintenance has been pretty much bad, and the constant deterioration of the infrastructure and the equipment had made obviously that our population does not have a really good healthcare service in the public area. And one of the things is these hospitals only survive, at least these two hospitals and the regional hospitals, they survive like just with our work as students. So if students are not here, if students are not working on the hospitals, the system is pretty much dead. Okay. So how about the financing? Yes, this little fluffy body here is all the Honduras healthcare system, because, and in total, our, like for example, our GDP is 8.5% lower than the average of the Americas. Like, for example, the average of the Americas GDP just for health, like the expenditure of the GDP just for health, is 14.1%, and here is just 8.5%. And according to public health expenditure as a percentage, for example, one of the lowest levels of investments corresponds to our country. There is just 101 US dollars per person. And the normal Latin American Caribbean situation is 392 US dollars per person. Here is just 101. And this is about 1/7 of the average. And the average should be 6 to 8 per person, like $628 per person. So yeah, this is pretty bad, obviously, for us and for our country and for our people. So yeah, and about the healthcare facilities. So we have like the network of the services is divided into 2 levels. So the second level has 29 units, and these are classified in 3 groups. That the first one is the national hospitals. The second one, the national hospitals, as you've seen, there's just the main ones are these 2. And these 2 is the Hospital Escuela Universitario, that is the first one here, and the Mario Catarino Rivas, that is in San Pedro Sula. So these are the 2 national hospitals, only 2 for 9 million people. And then the regional hospitals, that they are obviously on the different regions of the country. And then is the area hospitals, that they are even smaller, even with even worse conditions, that are in the little towns. So most of the hospitals date back to 1980s, and the only ones with the new facilities are the ones in different cities. But the most recent one is a new hospital just for pediatric specialties, and this is here in Tegucigalpa. So, and the health secretary network is like 1,600 establishments and 7 national hospitals. The biggest ones are just the 2 ones that I told you before, 6 regional hospitals and just 16 area hospitals. But then we have the primary healthcare service, okay? And the primary healthcare services are in the little communities that is divided into 436 little healthcare establishments, 1,078 more little establishments that are just that there are no doctors there. There's only nurses. 74 maternal and child clinics, and 3 peripheral emergency clinics. That these emergency clinics, they are pretty much just for emergencies. So yeah, so the national, the social service, okay, the East has only 2 hospitals. So 2 hospitals for all the people that has the social security service. And yeah, that's pretty much what I can tell you about the normal part of the facilities. So yeah, again, please defibrillate us because we're in a very bad shape right now. And what about the health professionals? In Honduras, there is a very outdated human resources policy, and there is no planning in the field or coordination between the different instances involved. In 2015, the health secretary had pretty much more than 2,546 permanent physicians. That is just 63.2% of the whole physicians in the country. The private sector has just 880 physicians. That is just 24% of the whole of all the doctors in the country. And the East only has 474 physicians. That is even lower. That is just 13% of the physicians. So speaking only in the context of the health secretary, that is our largest employer of doctors in 2015. It only increased from the 2000 to the 2015, only increased on 13% of medical professionals. And we have the biggest rate of recent graduated people, of recent graduated doctors since 2008. That is 23% of all the doctors that exist in Honduras. They don't have any medical employed. Yeah. So this is quite bad, obviously. And this is what I can tell you about the healthcare system on a really brief summary for not in order to not boring you. And this is the Honduras medical education system. So we have, this is our, this is our universities that offer medical education. There is just 3. So we have the national one, that is the public university, and we have these 2 universities. This is the Catholic one, and this is the 3rd one, that is mine, that is a private one. So the Catholic and the technological one, there's just they're private, and the national one is the public one. And how it is organ. Oh, wait. Let me see. Something crashed. Let me see. Sorry. Yeah, there it is. Now I can show you again. So there it is. And how it is organized. So we have five different areas here. So we have 7 to 8 years course in, well, it's not 3 blocks, it's 5 blocks. Sorry for the 3. And first one is the basic studies. That is, for example, Spanish, math, chemistry, biochemistry, physics, and physiology. These are our basic studies, just that all the people have to study this. And I say from 7 to 8 years because in 2 universities is 8th year and 1 university 7th. And the basic medical studies, obviously, as pathology, semiology, and pathophysiology, this is pretty much from 2nd year to 4th year in some universities, and in the first 2, and in mine, for example, is from 2nd to 3rd year only. Then the clinical rotations, as pediatric, gynecology, surgery, and all the clinical rotations that you can imagine. This is done in between the 5th and the 6th year in the public one and in the Catholic one, and in mine is between the 4th and the 5th year. And then we have the rotary internship that is pretty much the same as your internado, but here in the public university, they are paid to do this. Okay, so you have a really small salary that is pretty much nothing. And this internships, you have 3 months on each rotations. You have 3 months in general surgery, 3 in pediatrics, 3 in internal medicine, and 3 in gynecology and obstetrics. And why is this? So the internship and why they are paying us. So to all the interns, the state pay us just a really small amount of money to do the work from 2 to 5 medical doctors. Okay, so for them it's even better that just students do the work of a general medical doctor, in order for not paying him the big salary and just to pay us a really small amount that is pretty much just the 10% what a medical doctor earns, but we do the work for 2 to 5 medical doctors. So if you really want more questions about this, obviously I will answer them. And what about the social service? So we are one of the fewest countries that in our 8th year or 7th year, we have to, well, we don't receive our title until we do this. The social service is to go to a normal hospital or to a rural area, to the ones that you saw there as a Clipper or as a Sesamos, that is the little small healthcare centers. And we have to go there and work for 1 year. And for the public university, they also got paid a little bit more than in the internal, but for the private ones, we don't receive anything, and we have to do the work for 1 year just if we want to graduate ourselves. It's different from other medical education programs in our region that, for example, when you finish your internado, you're done and you can graduate, and if you want to work in the country, you will have to do the social service. Like, for example, in Ecuador, it's the only example that I can have right now. And so we work for the government for this year, and a lot of people say that, yeah, it's really good because it's on 1 more year to learn, but actually you're just giving your work to the government and they don't want to pay a general physician to do this because it's going to be even more expensive. So this is the university that I already told you, and the medical residencies is pretty much a difficult part to enter because they have really few spots for doing a residency here in Honduras. It depends. For example, the quality of them, they're good, but they're not perfect or as good as a lot of people wanted. So if a lot of people that do this, like for example, that have the general residency, like the general specialty, and they want to do a subspecialty, they have to go abroad, because we here the only subspecialty that they offer is oncology surgery, and the others, like for example, you cannot have cardiology here. Like we don't have a residency for cardiology, and we have a lot of time teaching medicine, but we haven't got to that point because of the bad, obviously the financing is really, really bad for the residencies and for the medical education system in the public sector, because the residencies are only offered in the public part. So they're the only one specialties offered, and it's really hard because, for example, for all of the physicians that graduated every year, there's only, like for example, 10 spots for pediatrics, 10 spots for general surgery, and there's really a small amount of physicians that have to work there. And also they are very bad. The payment is bad in comparison to a general doctor. So if you're a general doctor and you get an employment with our public healthcare system, you will receive more money than doing your residency, and even though you're doing more work. So, and you're studying at the same time. So this is what can I tell you about our systems, to be briefly and not get a lot of your time. So thank you.
Thank you very much, Gabriel. It was really nice to hear. And I think that many people did send some questions. So now we did a forms, and we have like a line which says like, this question is for Gabriel, this question is for Vero, this question is for Rafaela, this question is for Ihong, and Monique is gonna read some of them, and we start like working like this and answering them. Okay.
Thank you. Perfect.
Yes. The first questions, they ask for everyone. So like they ask in the question for Vero, for Rafaela and Ihong and Gabriel. So I guess all the four of you have to answer this. So they ask, have you heard about Brazilian health system before? And it came from your medical school or because of IFMSA?
I guess I can go first. Well, I heard from the Brazilian healthcare system when I was in my exchange. I did my exchange in Brazil, in Florianopolis, with DENEM, and it was something like that my tutors there teach me about. They teach me everything, so it came pretty much from both my medical education, because I was going on an exchange thanks to my school, but also from IFMSA.
Gabriel or Yihong and Rafaela.
Can you repeat the question for me, because I
Okay.
didn't understand fully?
Have you heard about
They
Brazilian
wrote it
health
in the
system
chat.
before? Yeah.
Oh, okay. I can go, or Rafaela can go, whoever can go. I don't care. No, go, Rafaela, go.
Go ahead.
Ladies first, ladies first.
All right. All right. Thank you so much. All right. So I actually haven't really had the chance to familiarize myself with the Brazilian health system because unfortunately, and that's something that saddens me a lot, our medical education system isn't really focused on abroad and on global health and on giving us like a very international perspective about health systems. So I kind of like, that's one of the reasons why I love IFMSA so much, because it kind of gives me that part of medical education which I feel is missing from our medical system. And so the pieces of information you've provided me today about the Brazilian system were really useful. And I have encountered a Brazilian medical student in my Skopje internship 2 summers ago. I did in Croatia. And we kind of like took this opportunity amongst us and all the interns to discuss about like all our own health system, and that was really enlightening. So I guess I still have a lot to learn, but yeah, everything like that, webinars and stuff, they are like gold to me, because you really give me a more open-minded and more enlightened view of global health.
Okay, so I can go next. For me, it's quite the same as Rafaela. I've never heard about the Brazilian health system before, and yeah, we don't learn that in medical school, sadly. But I'm super glad that because of IFMSA and because of this webinar, I got to learn more about the Brazilian health system. And yeah, I can't wait to learn more. And otherwise, I was at the regional meeting in Brazil, in Curitiba, in January. And yeah, I got to meet a lot of Brazilians. It was super fun. And so we got to exchange a bit about our cultures. But yeah, my knowledge is very limited on Brazilian health system, and I can't wait to learn more about it.
So I think I can go next. I have heard before about the Brazilian health system, but obviously this webinar really clarified this for me. But the thing is, I've heard it because of in our pre-departure trainings we talk about the healthcare systems. So in the 2 pre-departure trainings that I organized last year and last year, I've heard about Brazil, and I heard about the healthcare system of Brazil for the outgoings that we had that they were going to Brazil. And also being a Leo, and then I was being a Neo last year, a lot of my students said that they love the hospitals, and they give me a lot of feedback and information about the health system. So I quite knew a lot of things, but this webinar obviously clarified me a lot of stuff. So yeah.
That's perfect. Thank you. For our next question, yeah, that isn't in the down here. Is Quebec covered by both health systems, the one from Quebec and Medicare, or just one of them?
I will go ahead. But yeah, we are covered by both, since Medicare and the federal government partially funds Quebec's healthcare system. So we are eligible for both. And as I said earlier, if for example, I am from Quebec, I am a Quebec resident. If I travel to British Columbia or Ontario, I will be covered by either, by Medicare, because I'm a Canadian resident. So it's kind of like very versatile, and it kind of works all together.
Okay. Next question. It's still for Quebec. Are most medicine cover or only some? Does the system cover the price entirely, or is it still necessary to pay part of the price of the covered medicines? It's kind of confusing, but I hope you understand. They sound like that to us.
Okay, I can go ahead and Rafaela can complete. So yeah, actually, I think it depends on which services. For example, if you take the ambulance, if you call the 911 and take the ambulance, you have to pay for yourself. But however, for example, surgeries, they're all covered, and hospitalizations are all covered. And for some medications, sometimes they're all covered and sometimes they're partly covered. It really depends, but it's mostly entirely covered. It's pretty good.
Okay, perfect. The next question is for Vero. What is the main difference between Seguro Popular and the INSABI?
Sorry, I couldn't find the tab of the meeting. Mainly the Seguro Popular was or intended to cover all the people that wasn't insured yet for any of the other public healthcare systems, whereas INSABI tries to or intends to give and provide healthcare to everyone, like even foreign people and migrants that are in the country. However, since it was not yet organized in a correct way, we haven't had the enough funds. Since I was just when Gabriel was explaining about the amount of work that it's destinated, the amount of money that is destinated to healthcare coverage in the country, it was in Honduras it's 8, in Mexico is less than 5, so less than 5%. So the amount of money that we have cannot cover this like broad spectrum. And it was when Seguro Popular had a 260 list of diseases. INSABI just short it in and summarize it into more like important, yeah, more important or more or diseases that happen more than others. So yeah, I think that's a huge difference. And also Seguro Popular, which was created by an expert in health and public health and global health, whereas the INSABI was created from just people from the government that has not medicine experience or medical experience. And well, there's like a lot of things that I could continue to go on. Seguro Popular had this like security or contingency fund when INSABI does not have it, or at least doesn't have it yet. So yeah, there's mainly those are the most important differences.
Perfect. There is one more for Vero. Is the ENR is for free? ENR?
No, yeah, it's an arm. No, it's not for free. You have to pay around, I don't know how to say it in dollars. Just someone help me to convert it. It's 3,000 pesos, Mexican pesos. Um, I think I don't know how
I
much.
don't know. It's
Okay, I will convert it and then I will tell you. But that's not it. You have to pay to the hospitals if you want to apply to them. So if you want to apply to a certain hospital, they charge you for the application as well. So it can go from 3,000 pesos to 4,000 pesos, Mexican pesos, for each application and interview for each other hospital. If you don't want to apply to any hospital, then you can wait until the end to like all the hospitals of IMSS, which I explained later before. But it like you can go to whatever according to your score. So a lot of people just apply first. So yeah, you have to pay a lot to do the residency.
okay, perfect. Thank you, Vero. There's one more for Rafaela or Yihong, but I think she's left. What are the main points that we need to invest?
All right. Well, I apologize for our internet connection. Apparently, Quebec is not the best place to be for internet, but yeah. So the main points that need more investment definitely. I looked it up a bit, but there is no health coverage for foreigners. So if you come here, we're well renowned for our health coverage for our residents, but definitely there could be something done for people coming here, because it kind of says, hey, we don't really, it's not welcoming to go to a country where everybody doesn't have to pay anything, and then you go to visit and you have to pay everything from your own pocket. So that's definitely one of the things I would tackle if I had the power to. Something that would need more investment as well would be a bigger medication coverage, because there are still some things that aren't covered fully. For example, for diabetes, they have some pumps that auto inject insulin, so that you don't have to stick yourself, or you don't have to really, for example, for teenagers, it can be really hard and really struggling to manage with diabetes. And these types of pumps, maybe with some exceptions, but most of them aren't covered at all. So the families that want to provide the best treatment for their teenagers have to pay for them. Even so, we're supposed to have a medication coverage. So a broader medication coverage would definitely be an asset for our health system, for sure. And maybe, I don't know, like, of course, every of these things needs money, and we're like, I think half of our taxes and things are going to our health system. So it would increase the taxes and people would probably not be too happy about it. But if we could, it would be great to also add dentists and glasses and stuff for everyone, because most people usually neglect their mouth's health. If that's something that can be called that. I'm not really sure about the term, but they really neglect their like yearly visit to the dentist, because they're like, hey, I don't want to pay for that. I'm not supposed to pay for my health, and I don't want to pay for treatment. And then they're told they have to, I don't know, remove a tooth, and they're like, nah, I don't need that, but they actually would. And on the contrary, some dentists kind of, that's really sad, but they kind of take advantage of that system, and they're like, they know the patient needs to pay for every act, so they will increase the numbers of required acts because they want more money from them. So they wouldn't really require to remove, for example, 5 teeth, but they will suggest that to the patient so that they will receive more money at the end of the day. And that is a problem. So if we could manage to cover more services as medication and as dentists, it would probably be a better place. But again, there's always a money problem. So.
Yeah, thank you. So next question is for Gabriel. How is the population's relation with the health program?
Okay. So I guess that this question is related to how people accept here the health program. So in the first instances is really bad. A lot of people do their complaints every day. There have been a lot of social movements in order to start rising the financing of the health program. For example, from the whole national yearly, like the national budget, the government only puts 3% of the whole budget just for health, just 3%. And so this is pretty much unacceptable. And right now with COVID, we're pretty much seeing how we're like the disaster that we have, because there are a lot of people dying because of this, because we don't have enough medical doctors. We don't have, well, we have enough medical doctors, but not in the hospitals. So this is the bad part. A lot of people, they don't like anything about the health program. And just as a fun fact, this health program, that like this national model that we have, this was stated in 2012. But the fun fact is that this was a model that was instated in Colombia in the 1980s, but that didn't work. So we have a model that didn't work, and they put it here because it's cheaper. So yeah.
Okay, thank you, Gabriel. Next questions is also for everyone now. So, which is the health area least attended by the program in each country?
I'm just not sure if it's talking about like the health program in the health system or the medical program, but I will answer as if it was talking about the medical program. And I mentioned it before, but I really think our medical program should be more oriented towards global health and towards teaching us how it goes abroad and over our frontiers, so we can to witness or to travel or to be better doctors of the world. If that's a bit cheesy, but like to be more open-minded about everything that's going in the world and not just focusing about what's happening here, because it could be changing really fast and the frontiers are not what they were. And I think the doctors of the future should be aware of the differences between the health systems so that they can try to work towards building the best health system for them and for their communities. So yeah.
Who's next? I can go next. Okay, so the area least attended, I will answer pretty much as both. So in the healthcare program, the area that is least attended is the old people. So the old people has the less, they don't have, they supposed to have the attention of the healthcare service, but they always are the ones in the line, the last in the lines of waiting for medical consultation, for doing x-ray things and everything. And this is, I don't know what's the reason, surely, but yes, this is the most disattended part. And then about the medical program, I will answer just as Rafaela. Our medical education should be towards global health and should be towards not just about public health and what is happening right now here, because we have a lot of public health classes, but we really should understand about global health and how to be a good doctor in the future, not just about the medical education, like the medical like the scholar part about the theory and the practice, but also what abilities we should have to be, what abilities we should have to be a really good doctor in the future, and to treat people and to treat patient as patients, not just as an extra person that is just here in front of me. So yeah. Better.
Okay, so regarding to the healthcare system, I will say that probably there are rare diseases that are just left behind, and sometimes those have the most expensive programs or like treatments, and they cannot get the treatment even if they are born like in a family in poverty, because those are not covered by any program. So that's where a lot of organizations try to compensate with that, but it's not always good, or the effort is not always enough. And for the medical education program, um, as well as global health, as my peer said, right now, I think that in Mexico there's a lot of lack of medical education, ethical education, medical ethics, and that's something that probably will help a lot way the students see the patient not as a disease, but as a person that has like a background and a general context. And sometimes this is what I disagree on with my peers or college colleagues at school. But yeah, I think that as well as global health, medical ethics, and social like everything that covers what the patient needs, like the social studies and so on, should be covered in or should be included.
That's perfect. The next question is for Gabriel. Who has access to the public service there?
Okay, so the public access is intended to be for everyone, for the 100% of the population, but we know that that is not true. So if we divide our population between the three sector within three sectors of of economy wise, so all the people that has, like for example the rich people and a lot of money, they go to the private sector, even though everybody should have. And for example, right now, in the pandemics, you can see that all the hospitals are full, the public ones and the private ones. People that don't have money are going to the private ones and doing bargain and having a lot of money issues because of this. So it's intended to be for everyone, but it's not. So pretty much only 50% of the population to 60% of the population has access to the public system, and just 23% of the population has access to the Seguro Social. So yeah.
Perfect. The next question is for everyone again. What do you think about the healthcare system in Brazil?
I can start. I was telling the other exponents in the group, presenters in the group, that I received my yellow fever shot in Brazil when I did my exchange for free. And in my country, they charge a lot for the vaccine. So it was like amazing. And my first um, approach to what the SUS was when my tutor or the resident when were to which I was assigned to was writing a lot of paperwork, and he was like, "I will let you try something, but there's a lot of things that I have to do." And I was like asking why was he writing a lot, and he was just explaining what the Constitution said and the paperwork that the patient could ask from their patients, from their doctors, to ask for the medicines that they needed, even like it didn't matter how much they costed. Like for me, it was really amazing to see that that's something that was being respected. At least I know that it's different in the whole country, and maybe not all the centers are the same, but the main goal of the SUS, I think it's really nice. And I wish we had something similarly, at least in some of the countries in some of the states in Mexico. So that's something that I really loved, and I think that it's a really nice initiative. And just to finalize, by the way, it was $150 the cost of the NAR. So yeah, that was the only thing that I wanted to say.
I can go next if you want. So, what do you think about the health system in Brazil? Well, about the Sistema Único de Saúde. So I think that is really good. And this part that everyone, like all Brazilians, can have access to the primary sector, that is like the family medicine and all ambulatorial processes and hospitalizations without paying pretty much anything, and that is distributed according to necessities. I really like that, and that's what all medical students that's what we dream to have, a medical system, a medical healthcare system that is distributed by the needs and doing and increasing the equity, and at the end the justice that we need. So I really like it, and that's what can I say, because I haven't been inside the system, but I really like it. And even thinking about that, Monique, for example, told us that everybody, even foreigners, can have like for example, that we can go to a hospital and we're going to be attended just like a Brazilian. That's pretty nice. Thinking that I was in Brazil, and if I have an accident, they will have treated me the same way. That's really good.
Do you want to go, Yihan? I can finish.
Yeah, I can go with the question. So I really like that the Brazilian system, the SUS, is public and free. And I really like when you said that every person must be seen as a whole. I feel like it's super important to consider every person as a whole. And also, I felt that it was super cool that you guys have the popular participation feature, that everyone can and should participate on the system's decision. I found that super interesting.
Perfect. Now we will have the questions
Yeah,
for
and just
Gabriel.
quick.
Sorry.
Okay, well, yeah, go ahead.
No, sorry. You can talk.
Well, I just wanted to say something really similar as Gabriel, so that I like the fact that a foreigner can have access to a secondary health treatments without being a resident of Brazil. This is really, really different from our system, and I really encourage it a lot. So that's pretty amazing.
Thank you. We'll have questions for Gabriel now because he needs to go. There's still 4 questions for him, so we'll do it quick. Next one for Gabriel. Do students help the physicians, or they're literally their physician's job? For example, do prescribe medicines and do procedure without supervision? How many students per year per university?
Okay, yes, I know that this is very sad. And this is one of the things that people like about coming to an exchange here. I will explain a little bit. So, yes, we do not help physicians. We do the physician's job. We're just supervised by the specialty or the head of the room. Like, for example, if you're in internal medicine, there's just one, like the internal medicine specialty doctor that he has studied for 10, 20 years, and he's just supervising. And then there is, like, for example, maybe there is a social service student, but as an intern, you have to do pretty much everything. You have to prescribe medicine. You have you don't have like the power to prescribe medicines, but you use the signature and everything of the head of the department, because there's no enough doctors, so we have to do the work. And that's it's really bad, obviously. But if you really care, obviously, as a medical student, you will study even harder, because if you, like, for example, that's the only good. It's bad and good at the same time if you see it from the normal people perspective, and if you see it from the medical student perspective. If I do a mistake, and they're not going to do anything to me because I'm a student. But for example, we have to do the job, so obviously the hospital will have the responsibility of that, and the head of the department. So yes, we prescribe pretty much everything, and the first month maybe is with a little bit of supervision. And if, for example, if you're in general surgery, and then the other 2 months that you have in general surgery, you pretty much do everything by yourself, and you just present the patients and everything. But the whole day, if you have to do a procedure or something, you have to do it by yourself. And that's what people likes about the exchange, because they come and they can do things supervised by us as interns. So the interns supervise the exchange student, and they all also have like our head of the department as their tutor, right, for the general part. So yeah. And how many students per year per university? That really depends on how many people. But in total, we have like 800 students, or 1,000. No, sorry, 1,000 to 1,200 students per year from the whole country that goes, and they are divided between the whole country and all the regional hospitals and the national hospitals. Yeah.
Okay, next questions for Gabriel. So 22% of the doctor doesn't have employment because they prefer to pay cheaper. Should students do it?
Yeah, that's pretty much it. Yeah. So, for example, they don't, as I said, they don't employ the normal doctors because they will have to pay. I will do the fast calculation here in US dollars for you to convert it to reais. So, for example, let's say that a general doctor, monthly, he should earn 1,240 US dollars, and that's pretty much nothing. But as a intern, and you do the work from 2 to 5 medical doctors, you and if you're in the public school, you only will win monthly $272. So that's why they obviously prefer to have us there than to contract real like a lot of medical doctors, and that's why there's a lot of unemployment here, because they just use us as medical students in the internship, and they use the people in the last year that is the social service.
Okay. I think this is the last one specific for you. Even with COVID, old people are still the last, or something changed?
I think that's the other that. Yeah, I think we skipped one. But yeah, even with COVID, old people are still the last. No, this have changed, thankfully. All the old people right now here with the COVID, they are in the Hospital Maria. That is the one for pediatric specialties. Obviously, they're not a kid. They're not kids, but that's our best hospital. Talking about the infrastructure and about the equipment. So all the patients that are obviously with a higher possibility of dying because of COVID, they are there. Like the bad cases are in there. So that's pretty much the all people that go there right now.
When
Okay.
graduated students from Honduras need to go to another country to do his desired residency and wants to come back, does he need to attest equivalence?
Okay, so it's really weird because it depends where are you studying. For example, if you have a subspecialty or like, okay, so there's two options. If you're a medical doctor, like a general one, and you want to do your residency abroad, and if you came back here, yes, you will have to do a equivalency test. But if you're already, for example, a pediatrician, and you want to do and if you want to do your subspecialty on neonatology, for example, in Mexico, that is really near, and that's where all pretty much 90% of neonatologists are from Honduras. That are to study to Mexico, yeah. So if you graduate in Mexico, for example, in the National Institute of Pediatrics there, and you won't have to do anything. You just have to ask for a job here, and you pretty much won't have to do anything. And that's the same for all subspecialties. And if you go to Mexico, to Chile, and, and I think that yeah, it's pretty much it, oh, and Spain. But if it's another country, they will put a test to you, but it's pretty much easy because you're already the subspecialty in another country and you have all the experience, so you will pass it, obviously.
Okay, perfect. Now it's for Vero. What do you what do you do on the social service year? Is it one test for all residents around Mexico?
Okay, so two different and really broad questions. First, I will go with the residency. Yes, it's only one for even foreigners or people that live here. It's a general exam. All of the people that applies has the same exam. Uh, well, not the same because the exam is divided like uh, they divide all the people since you have to go and take the exam on their computers. Um, so it's divided in several days. Last year they were like 5 days, I think, different. This the same day in all the country. And well, I will just if you didn't hear, the exam cost $150 US dollars, $211 Canadian dollars, and 130 reais. So that's the amount that we pay for just the exam. You have to also pay for the interviews at the hospital. But yeah, you can apply. Even if you're a foreign student, you can apply it to the different hospitals and so on. And regarding the social service, where there's a lot of things that you can do during the social service, it can be divided in a lot of things. For example, you can be at a hospital or general hospital, such as just like when you're an intern and do um, as it's the same as in Honduras, but we don't get paid during the social service, not during the internship. Well, some places do pay, but like a lot of places do not pay for you as a student while you are in charge of the patients, and just like give for example, you can be at the hospital, at the cardiology department, or at the oncology department, and it depends on what the department wants you to do. You can also have another uh, spot that it's called university spot, where you can go to any department in the university and do stuff. It can be administrative. For example, I'm on my social service year, and I'm doing work with the exchange coordination. So basically, I'm just working as an administrative part of the faculty. You can also go to a rural community and be the main doctor, the main act like a family doctor there, because you're not a family doctor, but you're just a general doctor, but you're in charge of everything from the patients, the children's growth and health, children's care and vaccination, through the pregnant woman's just development of the baby up to the 32 week of the pregnancy, and all the things that happen around the small town. Um, and you can go to other specific parts, such as like the emergency parts that we have, or emergency organizations that we have. It varies a lot. You can do a lot of things when you are in during the social service, mostly regarding to the primary healthcare approach of the patient.
That's perfect. So the next questions, are you done or sorry?
Yeah, I'm done.
Okay, so next questions. Do you have actions aimed at health education? That's for everyone.
I'm not sure to understand the question, but I can try to answer it. So in Canada, there are like there's the Canada's food guide. Like the government give us recommendations on how to eat well and how much physical activities you have to do. And also there are a lot of advertisements. And for example, when you take the bus or the metro, there will be advertisements about like, for example, don't smoke or don't drink and drive. I'm not sure if I'm answering the question, but yeah, that's what we have in Canada. There are mostly advertisements, and for example, when you watch TV, there are also governmental ads that promote health education.
Here we have several prevention or healthcare promotion programs. There is a lot of like catchy songs that the government likes to just share with the people. Mostly, the one that does this a lot is IMSS, Instituto Mexicano del Seguro Social, which basically has like all that, like if some song is um, right now on the spotlight, they take the song and change the lyrics into a sort of medical way or medical prevention, but it's just mainly campaigns. And then they started this section as well in at the IMSS, where you were able to go and just check yourself for a general, like a just to weigh yourself, or see if you get the nutritionist help or so on. But we don't have like enough infrastructure for everyone, so uh, they are trying, but not well, not yet achieved. But yeah, mainly campaigns and so on.
Okay.
So now we've gone through all the questions, and we're gonna wrap up our webinar. And thanks to everyone who helped us and who joined us today. Thanks to our beloved guests who helped us learn new things today and learn a bit more about other countries and other cultures. And if you want to say something right now, feel welcome to do so.
Well, I would just say thank you for organizing such a wonderful webinar. It was a really amazing initiative, and hopefully I'll be attending as a spectator at the other editions of the webinar, and I was really honored to be here. So thank you again, and see you all guys soon in other webinars, I hope.
Thank you. So thank you, everyone, and thank you for all the presentation. It was pretty amazing. Everything you have said here, we learned a lot today, and I'm sure like all our students and everyone who was watching us like it too. I received a lot of message from my friends saying that they love it, so that's really nice. And for next week webinar, we will be Africa, and I can maybe share here the screen of the invitation. Will be next Sunday as well, so 1 week after here. And will be earlier a bit. I'll try to. Maybe it's not open.
So the next,
Okay, we will post it on our Instagram.
but instead of being starting at 5 p.m. in Brazilian time, it will be at 3 p.m. in Brazilian time, which is 6 p.m. GMT. Thank you for
Yes.
joining us.
Thank you so much.
Thank you for this initiative, and thank you for all the people watching.
Thank you. Bye, guys.
Bye bye.